So good afternoon everyone, thank you for joining us. In the following hour we are supporting a Dorc supported conference on vitreoretinal surgery. Actually there has been a few changes in the program. I will be giving the first presentation about surgery in high myopes. Zach Koshi will give a presentation on 27 gauge possibilities in complex vitrectomy cases. Frank Beckett is here to talk to us about complex pediatric cases with the EVA. And finally, Dean Elliott will show the analysis of some very complex surgical cases. Surgery in high myopes, actually, this is a quite specific talk, and I will only show you some of the practical approach that I follow when I'm treating a retinal detachment secondary to a macular hole in a high myope. We call this an open detachment. It's these eyes when you have a staphyloma in the rear side and the patient develops a macular hole. In that case, you can develop a central detachment. These are my financial disclosures. Dorc is reimbursing my travel to come here. The first issue that you encounter when you're treating such a patient is when you want to perform ILM peeling. You won't, of course, use a dye because these eyes are usually very faintly pigmented. It's very difficult to visualize the ILM without staining. But the problem is that if you use ILM glue to stain the ILM in such a case, well, there's a macular hole and the ILM will simply drop through the wall, and then you have your staining agent under the retina, which is not what you want. So how can you solve this problem? What I do is I install a very small drop of PFC on the macular hole, and that seals the hole. And after that, you can inject a cloud of ILM glue over this small drop of PFC, and you stain the ILM around the hole. It does not penetrate under the retina. Now, this is not so easy. You have to play a game like this where you have to balance the eye with your left hand or non-dominant hand in the correct position and then inject a bubble of PFC, but it can be done and shown here. Here you see a bubble of PFC balancing on the macular hole. I'm holding the eye in the same position with my left hand with the light pipe, and meanwhile I'm spraying ILM glue over the hole. Or over the bubble, and as you can see, the bubble nicely prevents the ILM glue from penetrating under the retina. This is a 23 gauge case. In these high myopes, I don't go to 27 gauge because I do not have enough passive flow possibilities when doing this. I don't think you need to take too much compromises. But sometimes it gets even more difficult to do this balancing of the eye, and that's when you have an elevated retinal surface. If in such case you want to use a PFCL bubble on the retina, it will instantaneously fall to the side. So what I do in these cases, well, I inject PFC, I make a larger bubble, so when this bubble increases, it will first not flatten the retina, it will push the fluid to the periphery, and you will have a concave shape of the central retina. Then you aspirate again this PFCL bubble till it's again a small bubble, and then you proceed, as I've shown before, you inject a cloud of ILM glue and you take it away again. This is such a case where you see a central detachment. First I'm injecting the PFCL, I'm aspirating again, and I'm moving the bubble over the fovea, and again you see here how the ILM glue can be injected now, while you can hold this bubble of PFC over the fovea, and here it's aspirated again, and the bubble is removed as well. A second issue that you may encounter is your ILM peeling. Don't forget that the retina is detached and in the area where you want to peel the eye. So when you grasp it, you will most likely lift the retina rather than removing the ILM. So what you can do here is, again, make use of PFC. So inject a relative amount of PFCL, you fill about half of the eye, and you can peel the ILM through the PFC. It feels different, and this is shown in this video. This is the PFCL being injected after staining with the ILM with ILM glue. And you just go through the bubble. Here I'm using a 23 gauge myopic forceps. Dorc has these are longer forceps than normal in these very long eyes, so you can more easily reach the ILM. And you see here when you peel the ILM, it comes off quite easily, but it's immediately pushed down to the retina by the PFC. Usually when you peel the ILM, it stands up when you peel it off. Here it's immediately flattened, but it can be done actually quite easily. I was impressed when I did it the first time. It doesn't take too much more effort doing it under PFC than doing it under PSS. This is another case. This shows the initiation of the ILM peel. You see how well it is stained, even in this high myopia case. You can easily see the edge of the peeling. But I'm mainly showing this because in a moment when I will be doing the other eye display, how the retina is even moving under PFC. So if you do not use PFC here, you can imagine how you would pull up the retina. Even with this weight of PFC on the retina, it's still moving a lot, but PFCL can be moved. When there's a lot of subretinal fluid, it's usually quite viscous because it's been there for a lot of time. So I try to remove it, and in my personal experience, I think it works best with air fill. When you fill the eye with air, the air will first float, of course, on top of the eye, on the superior part, and will gradually come down. And that way it pushes the fluid towards the macula hole. If you would do this with PFC, the PFC will push the subretinal fluid to the periphery, and it will be difficult to grasp it through the macula hole. If you use air, you will more have a push towards the center, and you can drain the subretinal fluid. Here I've made a drawing of a backflush instrument penetrating through the hole. Usually I do not do that. Usually I use a silicone tip backflush instrument, and I aspirate just above of the macula hole. It's not easy to film this because it's under air, but here this is a silicone tip instrument, and you see the movement of the fluid on the retina, showing that I'm passively aspirating this subretinal fluid. Now in these cases, I want to have a quite long-term tamponade to sometimes close the hole, not always, but at least flatten the retina. And so here I use heavy silicone oil. This is injected under air. You may never have heavy silicone oil be in contact with PFC. Never do a direct exchange because the PFC will dissolve into the heavy silicone oil. This is an injection cannula I'm using to fill the eye. And finally, I would like to show you an example of such a case. This is a case I operated a week ago. This is a pre-op image. Now this is a spectral domain OCT, so here's the optic disc. Here you see the retina detachment, and of course it bounces on the ceiling and it's bounced back the image, but it's easy to see that this is a rather extensive detachment. This is the 3D reconstruction. Again, it shows how elevated the retinal surface is. This is 3 days after surgery. The retina is in the central part completely reattached. The hole is not fully closed yet. It may still close, it may not. But in my experience, if you leave the heavy oil for a couple of months in the eye and you ask the patient to sleep on their back, usually when you take out the oil, it does not redetach. In the lower area, you still see some subretinal fluid. It's only 3 days after surgery. Usually after a couple of weeks, this residual fluid will also resolve in the postoperative phase. This is the 3D reconstruction. You see central reattached retina, and here you see edge of the macula, some residual fluid. Thank you. I would like to ask the next speaker to come forward. We will first give the 4 presentations, so the coach will show us some of his experience with 27 gauge, and we will introduce the opportunity to ask questions at the end of the 4 presentations.
Thank you, Dr. Stans. I'd like to thank Dorc for getting us all together for this session. My financial disclosures relevant to this talk are my travel gift submitted by Dorc. I'm a regular 23 gauge user, and I think a recent survey across VR surgeons of the globe has said that's perhaps the most common gauge being used in vitrectomy. So the question has to be asked, why 27? Because 23 does a perfectly acceptable job in most cases. go back to these pictures, and if you look at the picture on the top left, that's the original prototype projectome by Macular, which was 16 gauge. Things have moved on. We used 20 gauge for a long, long time, sutures, and the sutureless 20 gauge. The point was that there was a greater degree of mobility in a large gauge projectomy setup. And as we moved to a smaller gauge, things got better in a number of ways. There was less tissue disruption and morbidity, and patients felt that change in the lack of morbidity because there was less inflammation. We might not talk too much about this concept, but if there is less tissue disruption, especially in the conjunctival surface, problems with dry eyes does not tend to be such a big factor in the post-operative period. And we are aware of that in terms of cataract surgery, but we don't think much about that when it comes to VR surgery. But as our technology is improving, our thresholds for intervention are dropping, and we're getting better at achieving results, it's perhaps a good idea to now start looking at these finer aspects of the results that we achieve for our patients. Better wound closure, there's no doubt about that. Now, we do make an effort to go tangentially for 23 gauge to get a good wound seal because of the track that you're forming. I found that that's less and less necessary as you go to smaller gauges, particularly 27 gauge. And greater precision. The small instruments inside the eye, and particularly with the amount of vacuum, are able to titrate the pressure that you exert on various tissues, and I'll try and demonstrate that. But when I started, it was mostly as a trial of new technology. So what I'm going to be telling you today is really very much from the perspective of somebody who's trialing this in recent times. So my concerns were that speed, because as you go smaller in terms of bore size, the equation is pretty convincing that physics is going to reduce the amount of flow significantly to the power of 4. Rigidity of instruments, our earlier experience with 25 gauge, which is much better now, was again that there was a lot of problems, particularly in eyes that were deep set and long eyes. And therefore the robustness of these instruments was a factor that I was concerned about. The range of answer instruments, because if you're all working with a particular gauge, then you've got supporting instruments meant for that gauge, and if you bring a new gauge in, then you're going to bring a new set of instruments in, and are we able to replace one set completely with the other? And some theatre setups will find that an issue in terms of space and accommodation. And not to mention illumination, because that again, as you reduce the bore size, the degree of illumination that you're able to afford might be a lot less. So these were the things that I was a little worried about while taking on this technology. So my case mix so far is again a fair. I started off with macular work, so the bulk of the numbers that I've done is macular. Then as I got more comfortable with the adaptations to the technique, I was able to spread out to detachments and proliferative disease. The 27 gauge EVA system has got a few aspects to it which really make it stand out, and one is this twin duty cycle, and you probably have seen videos of it, and I'll show one later, where each excursion has got 2 cuts, and therefore the degree of cutting that's occurring off the vitreous as it's being aspirated is a lot more. And so even though we are going to a maximum of 8,000 excursions per cycle, it's doubled, so you effectively got a headline cut rate of 16,000 cuts per minute. And there's a quick responsive vacuum of 650, and the construction is reinforced stainless steel. So this is a video that I got from Dorc, which actually demonstrates the twin duty cycle principle. And because the cutting edge is on either side of the guillotine, each excursion has got 2 cuts to it. And this is a representation of that in real time in a practical sense. To the left is a standard projector with each excursion cutting once. And you can see that the degree of aspiration of the fluid appears to be quite rapid on the twin duty cycle projector. So while trialing this, I looked closely also at the setup and wound construction, which I felt would be one of the advantages. Would it create a proper PVD without any extra effort? Again, my intuitive impression was